Good day, dear great surgeons. Today we're gonna talk about the pre and post operative chapter. This is a very crucial chapter in every exam and have a main bulk and overlapping with many chapters. So pay attention and let's take this chapter together and with the voice shots we will take it over just like a piece of cake, God willing. So let's start together the journey with the pre and post operative chapter.
Remember that heparin causes the formation of complex between antithrombin and activated thrombin factor 7, 9, 10, 11, and 12. 7, 9, 10, 11, and 12. The advantage of low molecular weight heparin, the better bioavailability, the low risk of bleeding, and longer half-life. Little effect on PTT and prophylactic dosage. Less risk of HIT, the heparin-induced thrombocytopenia. This has less risk with heparin low molecular weight. But the complication of the low molecular weight may be bleeding, osteoporosis, heparin-induced cytopenia. Yes, it's less risk, but still exists in the complication statistically. It occurs about 5 to 14 days after the first exposure. Or anaphylaxis might be a complication as well. In surgical patients that may need rapid return to theater, administration of unfractionated heparin is preferred, such as low molecular weight heparin, which have longer duration of action and harder to reverse. Unfractionated heparin is generally cleared from the circulation within 2 hours, so this will allow plenty of time and this method of choice in elective setting. Protamine sulfate will reverse heparin. Protamine sulfate is the antidote of heparin, but this is still associated with risk of anaphylaxis and thus not generally used unless immediate reverse of anticoagulation is needed. Patients with metallic valve will generally stop unfractionated heparin 6 hours preoperatively. Clomazine antagonizes the effect of benzodiazepine by competition at the GABA binding site. Since many benzodiazepines have longer half-life than clomazine, patients still require close monitoring after receiving the drug, while doxapram would increase the respiratory rate. It's not an agent of reversal of midazolam. Doxapram will increase the respiratory rate, but it's not the agent of reversal of midazolam. Propofol has rapid onset of anesthesia with pain on IV injection and rapidly metabolized with little accumulation, proven to have antiemetic effect. The propofol has antiemetic effect, and this is a very common question in the exam, with moderate myocardial depression, widely used especially for maintaining sedation on intensive care unit, total IV anesthesia, and for day case surgery. The sodium thiobentone extremely rapid onset, making the agent of choice for rapid sequence of induction. If you want the rapid sequence of induction, choose sodium thiobentone, but take care. It metabolizes, build up quickly, and unstable for maintenance effusion, with little analgesic effect. But take care, it has a marked myocardial depression. Marked myocardial depression effect with thiobentone. If you have watched House series, ketamine, you will be familiar with ketamine. He used it for himself. May be used for induction of anesthesia, as well as has moderate strong analgesic properties. That's why remember House, when he has severe pain and used ketamine and improved his condition. So ketamine, remember House, it has a moderate to strong analgesic properties. Produces little myocardial depression. Unlike the thiobentone, sodium thiobentone has a marked myocardial depression, but the ketamine has little myocardial depression. But take care, it has induced state of dissociative anesthesia resulting in nightmares, and this occurred to Dr. House as well. Ketamine gave him analgesia and caused him to have hallucinations and nightmares. The etomidate has favorable cardiac safety profile. Take care, the etomidate loves the heart, but unfortunately, it will cause adrenal suppression. The etomidate loves the heart and hates the adrenals. It has no analgesic properties, and post-operative vomiting is common. So the ketamine causes strong analgesia. The etomidate has no analgesia. The ketamine will cause nightmare. Etomidate will cause harming of the adrenal and love the heart, unlike the sodium thiopentane, which has a depression on myocardial activity. Patients with aortic stenosis are major preoperative concern. They may have ventricular hypertrophy and can result in relative myocardial ischemia, and this increases the risk of arrhythmia. However, the main concern if they cannot increase their cardiac output, particularly if vasodilation occurs. Aortic stenosis is the narrowing of the aortic valve. May occur as a result of rheumatic fever or with aging or calcific changes as well. Congenitally may occur earlier due to calcification of the bicuspid aortic valve. Symptoms include exertional angina and syncope. Where the condition is suspected, transthoracic echocardiography is investigation of choice. The investigation of choice for aortic stenosis, thoracic echocardiography, whenever suspected. The preoperative management of patients with diabetes. They should be placed first on the operating list. Don't delay the diabetic to the end of the list, but make him the first of the list. Potassium supplementation is likely to be required in diabetic on a sliding scale. Electrolyte abnormalities are more common after major visceral resections, as well as a blood glucose monitoring is required during general anesthesia. Remember, for thyroid surgery, vocal cord check is a must. Remember, parathyroid surgery, consider methylene blue to identify the gland. Remember, for surgeries involving the thoracic duct, consider administration of cream. Remember, pheochromocytoma surgery will need alpha and beta blockage, both alpha and beta blockers. Remember, surgery for carcinoid tumor will need covering with octreotide. Remember, colorectal cases, bowel preparation, especially left side surgery. For emergency cases, preoperative preparation, stabilize and resuscitate. Consider whether antibiotics are needed and when and how they should be administered. Inform the blood bank of a major procedure planned, particularly where the coagulopathies are present at outside or anticipated, like rupture abdominal aortic aneurysm. Don't forget to consent and inform a relative if they are present. Wound healing. The surgical wounds are either incisional or excisional, and either clean or clean contaminated or dirty. Although the stages of wound healing are broadly similar, their contributions are vary according to the wound type. We have 4 stages in wound healing: hemostasis, inflammation, regeneration, and remodeling. We want to stress that during hemostasis, the vasospasm in adjacent vessels, platelet plug formed, and generation of fiber-rich clot. This is within minutes and hours. The inflammatory phase, where the neutrophil migrate, and this is the main cell during the inflammation, in addition to macrophage and fibroblast. This typically takes from 1 to 5 days. The inflammation from 1 to 5 days by the neutrophils mainly, while the regeneration typically from 7 to about 2 months, 7 days to 2 months, where the platelet-derived growth factors and transformation of growth factors stimulate fibroblast and epithelial cells. The fibroblast produce collagen, and angiogenesis occur. This is during regeneration. While during remodeling, from 6 weeks up to 1 year, this is the longest phase in healing process, the remodeling. During this phase, the fibroblasts become differentiated into myofibroblasts. And take care, this is a common questions exam about the myofibroblast. And these facilitate wound contraction. Collagen fiber are remodeling and microvessel regress, leaving a pale scar. So the scar is the end result of any wound. Myofibroblast in the remodeling phase, these have contractile phenotype and therefore help in contracting the wound. The immature fibroblast able to adhere to senior serum matrix but don't have this ability. The myofibroblasts have contractile phenotype, thus help in contracting the wound during the remodeling phase, which take from 6 weeks to 1 year. The damage to the lung substance may produce an air leak. Air leak will manifest himself as persistent pneumothorax that fails to settle despite the chest drainage. When suction is applied to the chest drainage system, active and persistent bubbling may be seen, although an anastomotic leak may produce a small pneumothorax. A large volume air leak is more indicative of lung injury. Take care during preparation of your surgery. There are some tips that may avoid complication during surgery and avoid you from the never event. The World Health Organization checklist now mandatory prior to all operation. Prophylactic antibiotic, right doses, right drug, right time. Assess for DVT and pulmonary embolism risk and ensure adequate prophylaxis. Mark the site of the surgery. Use tourniquet with caution and with respect for underlying structures. And take care regarding the tourniquet. Do you know that in the ATLS 10th edition now, you can use tourniquet unlike the previous edition? Let's continue about avoiding complications of the surgery. Remember the danger of the endarteries and situation where they occur. Avoid using adrenaline-containing solution and monopolar diathermy. Handle the tissue with care. Devitalized tissue serve as needles for infection. Be very wary for the potential of coupling injury when using diathermy during laparoscopic surgery. This means when you don't see the diathermy is burning the site where you are using it, it may have a coupling effect on another organ, so take care. The inferior epigastric artery is a favorite target of the laparoscopic port and surgical trains. Take care of some anatomical principles. Take care of some anatomical nerve that may be injured during your surgeries. The posterior triangle lymph node biopsy take care of the accessory spinal nerve. During posterior approach to a hip, take care of the sciatic nerve. The legs in the Lloyd-Davis position may cause common peroneal nerve palsy. Axillary node clearance may cause the long thoracic nerve palsy or even injury. Pelvic cancer surgery, take care of the pelvic autonomic nerve. This may cause impotence. During thyroid surgery, take care of the recurrent laryngeal nerves. In upper limb fracture repair, take care of the nerves like the ulnar and median nerve. In thyroidectomy, take care of the parathyroid gland. During colonic resection and gynecological surgeries, take care of the ureters. Use Verus needle to establish pneumoperitoneum may cause bowel perforation. That's why some surgeons prefer the open technique under vision instead of using the Verus needle for pneumoperitoneum. Pneumoperitoneum is insufflation of the intra-abdominal cavity with carbon dioxide because it's inert and absorbed. During laparoscopic cholecystectomy, when you are using the laparoscopy to identify the calloid triangle and you have failed to identify the anatomy of the calloid triangle and you can't get that safety view, you are very liable to cause bile duct injury. Take care. During ligation of the splenic hilum, take care of the tail of the pancreas. It's a very common record question. During the redo open hernia surgery, take care of the testicular vessels. To calculate the routine maintenance IV fluid for children and young people, take care. We use a holiday figure formula. The holiday figure formula stated this. We have the first 10 kilos, then the next 10 kilos, then over 20 kilos. The first 10 kilos calculate over 100 milli per kilo per day. Then the next 20 kilos calculate for 50 milli per kilo per day. Then above the 20 kilo, use 20 milli per kilo per day. So if you have a child 30 kilogram, what you will do? You have 3 tens. The first 10 kilos, you will multiply the 100 by the 10. The next 10 kilos, you will multiply the 50 by the 10. Then the third 10 kilos of the 30 kilogram baby, you will multiply the 10 kilo by 20 milligram per kg per day. Be aware that over 24-hour period, male rarely need more than 250 milli, and female rarely need more than 2000 milli of fluids. Maintenance dose for the neonates in the first day from 50 to 60 milli per kg per day, while the second day 70 to 80 milli per kg per day. From the first day to the fifth day, add 10 milli per kg per day from the start of the first day. Don't bother yourself with remembering too much numbering. We have from first day up to the first week, 7 days. We start at the first day from 50 to 60. We add 10 to the second day, so 70 to 80. If a child and neonate needing 3 days, so the first day was 50 to 60. So we'll add 10 and then 10, so it's from 70 to 80 in the second day and 80 to 100 in the third day. Hope it's clear. Take care. The ITP patient, the idiopathic thrombocytopenic purpura, causes splenic sequestration of the platelets, so the platelet transfusion should be carefully timed. Too soon will cause ineffective, and too late and unnecessary bleeding will occur. The optimal time is after the splenic artery has been ligated. Remember, warfarin affects the senses of factors 1972, 10, 9, 7, and 2, and protein C. A very famous question about the post-operative analgesia of a 6-month-old baby who has undergone orchidopexy, of course, may be due to undescended testes. During orchidopexy, it can be quite uncomfortable immediately following the surgery, and thus caudal block can be very effective adjunct and provide good analgesia. The spinal block and epidural block would be inappropriate. Even the tap block may cover the inguinal canal, but this is not generally reliable, and wound catheters are not used during the orchidopexy. This is a very famous recall question, yet it's even from the MRCS. Talks about 70-year-old man with prostate cancer admitted to urology with urine retention and complains of back pain, which is not responding to analgesia, and the imaging shows metastasis. So we have 70-year-old patient, prostate cancer, and vertebral body mets. What is the most appropriate management? The fact that the word-based management analgesia has been tried suggested that the patient be considered for palliative radiotherapy. Surgical resection of the prostate cancer polymetastasis is not generally performed, so he will undergo radiotherapy to the lumbar spine. Again, 70-year-old man with prostate cancer with vertebral body metastasis. He doesn't respond to analgesia. Arrange for radiotherapy to the lumbar spine. Most of the patients with cerebrovascular accident will undergo percutaneous endoscopic gastrostomy. However, an esophagectomy will preclude this because the stomach will be intrathoracic. So, in a patient like this, jejunostomy tube will be inserted, surgically inserted. Feeding jejunostomy is more safe in the patient with esophagectomy and cerebrovascular accident. The complication of transurethral resection is TURP. TUR syndrome, urethral stricture, and retrograde ejaculation perforation of the prostate. The TURP operation, transurethral resection, will cause TURP complication, TUR syndrome, urethral stricture, retrograde ejaculation, and perforation of the prostate. The TUR syndrome, TUR syndrome, occur when irrigation fluid enters the systemic circulation. The triad feature of the TUR syndrome, hyponatremia, fluid overload, and glycine toxicity. Management includes fluid restriction and the treatment of the complication associated with hyponatremia. Remember, aminoglycosides are nephrotoxic and ototoxic. Nephro-ototoxic. Both nephrotoxic and ototoxic with the aminoglycoside. Groups are class of drugs that increase the force of the cardiac contractility. This may improve cardiac output. Increased blood pressure may have direct beneficial effect for the heart, and that improves the myocardial perfusion pressure. Dopamine and dobutamine are both commonly used inotropes. They should be administered via central line and in monitored setting. Glucagon and thiophelin are also positive inotropes, although not commonly used for this purpose, but they are inotropes, the glucagon and thiophelin. And this reminds us of the sodium thiopentane, which causes myocardial depression. For limited endoscopy, a simple enema will be sufficient, just like a single phosphate enema 30 minutes pre the procedures. Endoscopy is not laparoscopy. Don't confuse endoscopy with laparoscopy. Endoscopy is a tube that enters through a normal lumen of the body, like the oral cavity or the mouth or the anal cavity as well. The tube is entered with the camera inserted to know it. So you can do gastroscopy, colonoscopy, cystoscopy, ERCP, or even bronchoscopy. And this is completely different from the laparoscopy. During laparoscopy, we have to insufflate the intraperitoneal cavity with carbon dioxide gas to insert our ports and insert the camera through these ports to see the internal peritoneal cavity content. Most of the endoscopies has flexible instrument with 3 channels and a video chip with illumination source at the end. The channels are one for suction, one for irrigation, and one for instrumentation. With the flexible instrument, there is a control stick with a wheel that allows the tip of the instrument to be manipulated. Some procedures cause the patient sedation and others doesn't. Endoscopy should be usually performed in dedicated units and appropriately trained staff to gain a good result. It's a highly operator dependent and for resuscitation facilitate available because any accident might occur. Portacasts are a good choice for children as they are only accessed when they are needed, while the Propicast would pose the same core problem as the Hickman. Notice that the line of the Hickman is outside the body and always accessible and may be liable for infection, while the Portacast is hidden valve under the skin, only accessed when needed. There is a good evidence to support the usage of extended thromboprophylaxis after pelvic cancer surgery. So don't confuse the low dose and high dose of low molecular weight heparin. The low dose and high dose of the low molecular weight heparin, don't mix them. Read the options quite clearly if you got the answer long. The daily dose, daily low dose, low molecular weight for 4 weeks. This is a good evidence. Thromboprophylaxis in surgical patients. Deep venous thrombosis may develop insidiously in many surgical patients and may pass untreated. It may progress to result up to pulmonary embolism, and the lungs are important, right? A little bit important. So, let's have some risk factors for deep venous thrombosis. When to give thromboprophylaxis? If the surgery is greater than 90 minutes at any site or greater than 60 minutes involving lower limb or pelvis. Acute admission with inflammatory process involving the abdominal cavity. Expected significant reduction in mobility. Age over 60. Known malignancy. Thrombophilia. Previous thrombosis. BMI above 30. Take hormone replacement therapy or even contraceptive pill. The contraceptive pills increase the liability to thrombosis, even varicose vein with phlebitis. How to do a mechanical thromboprophylaxis? You have to encourage your patient to early immobilization after surgery. Please make him early ambulate after surgery. It's cheap and effective. Compression stocking. Use a crepe bandage or compression stocking, but it's contraindicated in peripheral arterial disease. Take care. Take care that compression stocking is good mechanical thromboprophylaxis. I like it a lot, but contraindicated in peripheral arterial disease will cause him to lose his already injured ischemic limb. Intermittent pneumatic compression devices are very good, but who has the money to get them? The foot impulse devices, this is luxury. So early ambulation, cheap and effective. You can use easily compression stocking and intermittent pneumatic compression and foot impulse devices. After thyroidectomy, there are some complications to take care of, like recurrent laryngeal nerve injury or damage to the parathyroid gland, which will cause hypocalcemia. But it's not normal to have a bleeding post-thyroidectomy, but it's a complication. So take care. When the exam tell you that he has confined space hematoma, will rapidly lead to respiratory compromisation onto laryngeal edema. So the hematoma will cause respiratory compromisation onto the laryngeal edema. And the key in the exam will be about a swelling existing. He will not tease you without giving you a clue, because I know you are thinking about a lot of things, especially the laryngeal nerve injury. But when telling you about swelling, what swelling should be after thyroidectomy? We put a drain. Lidocaine is very famous. It's very widely used. The most popular local anesthetic at all. But it shouldn't be used in patients with unstable disorder of cardiac rhythm, and ideally shouldn't be used or co-administered with other antiarrhythmic drugs. Take care. Lidocaine, the lignocaine, is an amide. It's a local anesthetic. It is commonly used as antiarrhythmic. It affects the sodium channel in the axon. The mode of action is very common record. It affects the sodium channel of the axon. It has a hepatic metabolism and protein-bound renal excreted. So it metabolizes in the hepatic, in the liver, and excreted via the renal route. It has toxicity due to IV or excess administration, so take care while injection to aspirate before injection, or else you will have lidocaine toxicity. The drug interaction with the beta blocker and ciprofloxacin and phenytoin, and please don't give with the anti-arrhythmic drug, especially in the cardiac rhythm disorder patient. It features the toxicity like initial CNS overactivity, then depression, because initially the lidocaine initially blocks inhibitory pathway, then blocks both inhibitory and activating pathway. This is cause cardiac arrhythmia. Increased dose may be used when combined with adrenaline to limit systemic absorption. The immediate treatment of hypercalcemia, fluid resuscitation via sodium chloride IV. Again, the immediate treatment of hypercalcemia, IV sodium chloride 0.9%. Hypercalcemia, you can combine the intravenous sodium chloride with a complement of biphosphonate and sometimes diuretics, but the immediate treatment is IV sodium chloride. Very common question in the exam. Remember, hypercalcemia will cause shortening of the QT interval. If the ECG changes, hypercalcemia will cause QT interval to be shortened in the ECG changes. Remember, pregabalin is the first-line agent for neuropathic pain. Neuropathic pain, first line is pregabalin. Remember, dexamethasone is depolarizing neuromuscular blocker. It inhibits the action of acetylcholine at the neuromuscular junction. Degraded by the plasma choline esterase and acetylcholine esterase, affected by the lack of acetylcholine esterase. It has fastest onset and shortest duration of action of all muscle relaxant. Produce generalized muscle contraction prior to the paralysis. It has contraction prior to the paralysis. Has adverse effect like hyperkalemia and malignant hyperthermia. Malignant hyperthermia is treated by dantrolene, as long as I can remember. Dexamethasone is degraded by the choline esterase and acetylcholine esterase. Atrachium and vincuronium and pancuronium are all non-depolarizing neuromuscular blocking drugs. Atrachium, vincuronium are all non-depolarizing neuromuscular drugs that are reversed by neostigmine. The three are reversed by neostigmine, except for the dexamethasone is reversed by the choline esterase and acetylcholine esterase. The patient who needs fluid replacement due to third space loss, a large third space loss, should be replaced by Hartmann solution, because normal saline would put the patient in the risk of hyperchlorimic acidosis, and this is a very common recall question in the exam. And this follows the protocol of the ATLS 10th edition. Scoring system, the American Society of Anesthesiologists Physical Status Scoring System, the ASA scoring, is a very common question in the exam. Roughly memorize that grade 1, no organic or physiological biochemical psychiatric disturbance at all. 1 is normal human being. But 2, score 2, mild to moderate systemic disruption. Score 3, severe systemic disruption. 4, the patient has severe systemic disease or illness that threatens his life. While the ASA score 5, the patient who is morbid and will not survive without surgery. And when you add a letter E, is emergency. B. Consent. Consent is a very famous question in the exam, and you have to know that in UK they use forms. We have 4 forms numbered: Form 1, Form 2, Form 3, and Form 4. And you have to know which form will be used in each situation by the number, because it will be asked in the exam, what form will you use in this situation? The consent form 1 is for adult, able to consent for themselves for an operation or intervention that will require him to be unconscious, like GA, general anesthesia. So, consent form 1 for competent adult who are able to consent for themselves where consciousness may be impaired, like general anesthesia. Consent form 2 is for an adult consenting on behalf of a child where consciousness is impaired, where the consciousness of the child will be impaired, so the adult will consent for the child. This is consent form 2. The consent form 3, adult or a child where consciousness is not impaired, we will do a local anesthesia operation or a local anesthesia intervention, you will be using consent form 3. You will be using consent form 3. Consent form 4 for an adult that lack capacity to provide informed consent. So, what is capacity? Capacity key points include understand and retain information. The patient believes the information to be true. The patient is able to, with the information, to make a decision and understand what you are telling him about the intervention you are going to do. All patients must be assumed to be having capacity. When you are consenting a minor, the young children and older children who are not GELEC competent can't consent for themselves. In British law, the patient biological mother can always provide a consent. The child's father can consent if the parents are married and the father is a biological father, or if the father is named on the birth certificate. In the certificate, if the father giving his name for the child, he can consent for him, irrespective for marital status. So if the mother and father for any reason divorced, but the father is a biological, or giving him his name in the certificate of birth, he can consent for him, for the child. Take care, if the parents aren't married and the father is not named on the birth certificate of the child, then the father can't consent for the child. So if the father willing to consent for the child, he must be the biological father and giving the name for the child in the birth certificate. Level of evidence in MRCS is very important and very direct question in the exams. So let's be familiar with the 5 level of evidence. The level of evidence from 1 to 5, 1 is the highest evidence level, 5 is the lowest evidence level. 5 is like telling your opinion if you are expert. So when you are telling your opinion regarding doing a dressing or doing a technique or doing something without evidence or the approved evidence for this, you just practiced a lot and telling you are knowing that this is done like this. This is a very low evidence. This is level 5 evidence. Level 4 evidence is from case series or case reports. So you are not just telling your experience, but you have been presenting some cases and telling the result of this casing using your maneuver. So this is called level 4 evidence. Level 3 evidence from correlation and comparative study or use of historical control. You are using a comparative study of a previously done technique in old patient or previous patient. You are correlating the result of previous operation done on previous patient, not just recent patient. The evidence level 2 is the evidence derived from least one probably designed randomized control trial, and specifically like a cohort study for prospective study. You are generating a new study and going to follow up those patients for a certain time. The longer the better. The larger the scale of the patient will be better. Level 1 evidence is the strongest evidence. It's from the meta-analysis of randomized controlled trial. Meta-analysis roughly is combining all the studies talking about the topic you are going to search for and telling the result of those meta-analysis series. Atropine is muscarinic receptor antagonist. It competitive antagonist for the muscarinic acetylcholine receptor. Therefore, it inhibits the parasympathetic activity. It was traditionally used as pre-medication for anesthesia because it reduces the bronchial secretion and the salivary secretion as well. And bradycardia is reduced from increased vagal tone on anesthesia induction. Modern anesthesia techniques have reduced the need for this drug. Other effects of this drug include urine retention and pupillary dilatation. For your own knowledge, Atropine previously in the Middle Ages was used to give the look of the pupillary dilatation because they believed that the wide eye is a sign of beauty and called belladonna sign. This is using the atropine. Of course, in our operation, we use atropine or the anesthesiologist introduce atropine to decrease the secretion. Until now, we use it in Egypt. Drugs used in children are frequently asked in the exam. And a very tricky question is asking about a 5-year-old baby who is going to have a closure of a loop colostomy. What thromboprophylaxis would you be using in this case? 5-year-old baby going to do a loop colostomy. What thromboprophylaxis should be used? In pediatric surgical practice, the use of heparin type agent is rare. This is because even with abdominal surgery, children are ambulant and will have to mobilize early and soon after surgery, and DVT is very rare in this population. When to give a thromboprophylactic therapy? There is a risk group patient that might indicate a high risk group for thromboprophylaxis. If the surgery is greater than 90 minutes at any site of the body, or greater than 60 minutes if the procedure involves the lower limb of the pelvis. Acute admission with inflammatory process involving abdominal cavity. Expected significant reduction in mobility. Age over 60 years, or the patient have a known malignancy, thrombophilia or previous thrombosis, or the BMI above 30, or the patient is taking a hormone replacement, like even a contraceptive pills. This is important in the history. Even varicose vein with phlebitis or varicose vein itself is a risk factor. So take care when to give a thromboprophylaxis to reduce the risk for VTE or pulmonary embolism or DVT. Thromboprophylaxis can be done mechanically or medically. Mechanically by early ambulation and compression stocking and intermittent pneumatic compression and foot impulse device. This is the mechanical thromboprophylaxis. A very known risk factor for development of hyperchlorimic metabolic acidosis is the excessive infusion of normal saline because it has the greatest chloride content. So take care, saline will develop hyperchlorimic metabolic acidosis if massively introduced without control, with no need. That's why in resuscitation, Laryngeal lactate is preferred than normal saline, and for many other reasons, but this is specifically. During surgery, you must have encountered what is called diathermy or bipolar. So all of this is under the great topic of electrosurgery. Electrosurgery utilizes the heat generated by the passage of high frequency alternating electrical current through living tissue. The application of voltage across human tissue results in formation of an electric circuit between the voltage source and the tissue. In electrosurgery, the tissue acts as resistor, and the level of resistance is determined by water content of the tissue. It is the resistance that results in the formation of the heat. In electrosurgery, types of current are cutting, coagulation, desiccation, vulgation, and blending. Cutting electrosurgery. From its name, it causes precise cutting without thermal damage. Precise cutting without thermal damage. It's a sinusoidal non-modulated waveform. Sinusoidal non-modulated waveform. High average power and current density. High average power and current density. This is the cutting electrosurgery. Coagulation electrosurgery. It results in formation of a coagulum from its name. Result in formation of coagulum. It's a modulated current with intermittent dampened sine wave of high peak voltage. It causes evaporation rather than vaporization. Evaporation rather than vaporization, that is coagulation. of intracellular fluid occur in coagulation process, and again it results in formation of coagulum. So coagulation, coagulum, evaporation, modulated current with intermittent dependent dampened sine waves of high peak voltage. Desiccation, desiccation electrosurgery. It results in loss of cellular water but no protein damage. So no coagulum, no protein damage. In desiccation, it's an active electrode in direct contact with the tissue. Take care, in desiccation, active electrode in direct contact with the tissue because vulgration is held away from the tissue. The desiccation, it causes loss of water but no protein damage, and the active electrode in direct contact with the tissue. Low current and high voltage system. Vulgration. From its name, it's a vulgar. Its probe is held away from the tissue but cause low amplitude and high voltage, produces spray effect with local superficial tissue destruction. Blending electrosurgery. Blending electrosurgery is alternating cutting and coagulation mode. So you can say it's a mix between the cutting and coagulation, alternating cutting coagulation. Total average power is less than the cutting. Total average power is less than the cutting. Bethylene and morphine have different structure. Bethylene is much more lipid soluble than morphine and produce less biliary tract spasm than morphine. So to choose between morphine and bethylene in biliary tract pain, of course we will choose bethylene. Use of benzodiazepine preoperative reduce long-term postoperative cognitive impairment. Postoperative cognitive dysfunction management. What is the postoperative cognitive dysfunction management? It is the management of the deterioration of performance in the battery of neuropsychological tests that would be expected in less than 3.5% of control. Or you can say it's the long-term possible permanent disabling deterioration in cognitive function following surgery. Early, increased age, general anesthesia rather than the regional, the duration of anesthesia, the reoperation, the post-operative infection, all of this may increase the post-operative cognitive dysfunction. And late, due to increased age, emboli or biochemical disturbance. Take care if a patient is malnourished, with unsafe swallowing, or a non-functional GIT tract, or has a perforation, or inaccessible, then consider preoperative parenteral feeding TPN. Metaraminol is an alpha receptor agonist, and in general rule, inotrope and vasopressor can only be administered via central line. Metaraminol is an exception to this and can be administered via a peripheral line. The inotrope and vasopressor administered via central line, except metaraminol, which can be administered via peripheral line. Take care. So Propofol, proven anti-emetic properties, sodium thiobentone is extremely rapid during induction but have a myocardial depression activity, and the ketamine have analgesia as well as dissociative anesthesia result in nightmare, while etomidate is safe for the heart, killer and depressive for the adrenals. In cardiogenic shock, pulmonary pressure are often high. Remember this note. In cardiogenic shock, pulmonary pressure are often high. Noradrenaline and adrenaline, both from the adrenal gland, but the noradrenaline mainly alpha agonist, while the adrenaline is alpha and beta receptor agonist. Noradrenaline is vasopressor action with minimal effect over the cardiac output, while the adrenaline increases the cardiac output and the peripheral vascular resistance because it has alpha and beta receptor agonist, and the beta is PP inhibitory except for the heart, while the alpha is alpha. A famous recall question about an intravenous flow combination used in a 2-year-old baby with high output ileostomy. In high output ileostomy in a 2-year-old child, we use saline or saline added with potassium. Saline and potassium. Saline 0.9% please. 0.9% saline and potassium. Remember, with RBC infusion, pyrexia is the most common adverse effect, while with fresh frozen plasma, urticaria is the most common event adverse effect can happen. So RBCs or packed RBCs, pyrexia, fresh frozen plasma, urticaria, fresh frozen plasma, urticaria. Tracheostomy reduces the work of breathing and the space, useful in slow weaning. And a very famous question asks you about a patient in intensive care unit. He has been there for a week on respiratory distress syndrome and ventilated. So tracheostomy is often used to facilitate long-term weaning. The patient has been there for a week. The percutaneous devices are popular. These involve Seldinger type insertion of a tube. A second operator insert a bronchoscope to ensure the device is not advanced through the posterior of the trachea, and complications include damage of the adjacent structure and bleeding. Contraindicated in coagulopathy. Take care, tracheostomy is contraindicated in coagulopathy. Regarding the endotracheal tube intubation, provide optimal control of the airway once the cuff inflated, and may be used for long or short-term ventilation. Errors in insertion may result in esophageal intubation, therefore end-tidal carbon dioxide usually measured. Paralysis often required. You have to paralyze the patient to be able to give him endotracheal intubation. And higher ventilation pressure can be used with the endotracheal tube. Why we are talking about the high ventilation pressure? Because the laryngeal mask not suitable for high pressure ventilation. Take care. The laryngeal mask can't be used with high pressure ventilation, while the endotracheal tube can be used with high ventilation pressure. The oropharyngeal airway used to be easily inserted. No paralysis required. Ideal for very short procedure, and most often used as a bridge to a more definitive airway. You can change it during the operation to another more advanced definitive airway if needed. Transfusion associated with graft versus host disease occur 4 to 30 days after a transfusion and follow a subacute pathway. Patient may also have diarrhea or abnormal liver function test, and management involve steroid therapy. Take care about the complication after transfusion is very important. A very famous question about immunocompromised patient with leukemia, for example, came to you one day to take blood transfusion unit, and 5 days after this transfusion he came to the emergency department with fever, erythroderma and desquamation. This is a graft versus host disease. This is a transfusion of unirradiated blood in immunosuppressed patient. SOFA score is the sequential sepsis-related organ failure assessment score. SOFA score is a sequential sepsis-related organ failure assessment score. It's used with some parameters. Most questions ask you about what parameters are used in the SOFA score. The SOFA score uses the PO2 and PHI-O2, the platelets, bilirubin, cardiovascular, and Glasgow Coma Scale, creatinine, and urine output. Again, the PO2, PHI-O2, platelets, bilirubin, cardiovascular, Glasgow Coma Scale, creatinine, and urine output. So take care. The trick in the SOFA is that it uses the creatinine but doesn't ask you about the urea. Again, the SOFA score asks you about the creatinine, not about the urea, and asks you about the urine output. So, the SOFA score, PO2 over PHI-O2 and platelets, bilirubin, cardiovascular, Glasgow Coma Scale, creatinine, and urine output, but doesn't use the urea scoring in this score. Take care. Let's recall question about the preterm intravenous fluid. A 4-week-year-old preterm neonate has had inguinal hernia. What should be administered after the operation? The neonates are considered a high risk for hypoglycemia following surgery, and there you should give him 10% dextrose initially. Vasopressin is useful in managing the bleeding from the commonest type of von Willebrand disease. The vasopressin is less likely to be disease specific, and at most would have a vasoconstrictor approach, which is likely to be a brief duration. Noradrenaline is alpha agonist, while the adrenaline is alpha and beta agonist. The dopamine is beta 1 agonist, and the dobutamine with the longest term than dopamine is beta and beta 1, beta 2 agonist. So the dopamine is beta 1 agonist. The dobutamine is beta 1, beta 2 agonist. While the milrinone is phosphodiesterase inhibitor, which causes elevation of cyclic AMP level to improve muscular contractility and short half-life and act as vasodilator. Did you know that the salicylate overdose lead to a mixed respiratory alkalosis and metabolic acidosis? In adult respiratory distress syndrome, the ARDS, a Swan-Ganz catheter would typically have a reading of less than 18 mm mercury, not excess, but less than 18 mm mercury, because the right heart pressure should be normal. In acute respiratory distress syndrome, it's a non-cardiogenic pulmonary edema, non-cardiogenic, so the heart, by definition, must be normal. The adult respiratory distress syndrome is acute condition characterized by bilateral pulmonary infiltrate and severe hypoxemia, simply non-cardiogenic pulmonary edema. It's subdivided into two stages. The early stage consists of exudate phase. The exudative phase is the early stage of the ARDS. And the later stage is one of repair and consists of fibroproliferative changes. So the early stage, exudative phase, and the later stage, fibroproliferative change. Subsequently, scarring may result in poor lung function after the acute respiratory distress syndrome. It's very important, very common in every exam and even in your life, whatever your specialty is. Adult respiratory distress syndrome is non-cardiogenic pulmonary edema. The heart, by definition, must be normal, and the wedge pressure by the Swan-Ganz catheter must be less than 18. Management of ARDS, the acute respiratory distress syndrome management, treats the underlying cause. Antibiotic might be used if signs of sepsis occur. Negative fluid balance, in example, you have to give diuretic because we have non-cardiogenic pulmonary edema. We have to resolve the edema by negative fluid balance. Recruitment maneuvers such as prone ventilation, use of positive end expiratory pressure, and mechanical ventilation strategy using low tidal volume, as conventional tidal volume may cause lung injury in addition to the non-cardiogenic pulmonary edema, which will cause fibroproliferative change and scarring. So take care. Please use low tidal volume in ARDS. Because conventional tidal volume may cause lung injury. Only treatment found to improve the survival rate. This is the only treatment found to improve the survival rate. There are many causes for respiratory distress syndrome, but you have to be suspicious. When you found someone in sepsis or have direct lung injury or both traumatic or with acute pancreatitis, lung pore fracture, or even head injury, and you found him suddenly became dyspneic with his lab showing multi-organ failure, please suspect ARDS. Don't let him die in peace. You can save him by just suspecting that ARDS might have been occurred to this patient. Acute dyspnea and hypoxemia, this will occur in hours and days after the event with multi-organ failure. Malignant hyperthermia. Malignant hyperthermia is very rare, but may it occur with succinylcholine in a patient with genetic defect. He is a very unlucky patient. You have to have in your anesthesia or operating room the dantrolene, which is the antidote of the succinylcholine. Succinylcholine might cause malignant hypercalcemia in patients with genetic defect, and the only antidote will be denturine. Dexamethasone will cause malignant hypercalcemia, and very rare. We have to know that halothane is largely historically known for its hepatotoxicity. Halothane with an H causes hepatotoxicity with an H, and very common. With tetrahydroisoquinoline, such as atracam, can cause histamine release, while vicronium and dexamethasone doesn't cause histamine release. Again, tetrahydroisoquinoline like atracam, topicarine, doxycycline, and mivacurine all will cause histamine release, but the vicronium and dexamethasone doesn't cause histamine release. TBN solutions are very irritant to the veins, thus they are preferred to be given via central line. And take care, the femoral root have higher incidence of sepsis, so be avoided in TBN as much as possible. So the best route will be like internal jugular vein with ventral venous catheter for TBN solutions, because they are very irritant to the veins. Take care. The total parenteral nutrition solution might have lipid, potassium, glucose, magnesium, but never fiber. There is no indication for including a fiber in the TBN solution. And even if you need fibers in the patient, it's not safe to give fiber via TBN route. Take care. Definition of enteral feeding. Enteral feeding refers to intake of food via GIT, the whole GIT tract. So, enteral feeding in case of upper GI dysfunction won't be through a gastric feeding, but we can do duodenal or jejunal tube, right? So you can consider enteral feeding in upper GI dysfunction. We can use duodenal or jejunal tube. In acute dystonic reaction, don't give antidopaminergic drug. Antidopaminergic drug in acute dystonic reaction will worsen the situation. Procyclidine will help to reverse the event. Procyclidine will help to reverse this event. Hyperacute T or peak T in ECG is the first and most common finding for hyperkalemia. The feature of hyperkalemia in ECG is very common in the exam. The most common feature is peaking or hyperacute T wave, the loss of the P waves, broad QRS complex, and ventricular fibrillation, which will occur first from those four signs, the peaking of the T wave. So you will see loss of the P wave, broad QRS, and ventricular fibrillation, but mainly the first will be peaking of the T wave. When you see a pink serous fluid out of any wound, especially a closed abdomen, is early sign for abdominal wound dehiscence with possible evisceration. If this occurs, you should remove one or two sutures in the skin and explore the wound manually using sterile gloves. If there is a separation of the rectus fascia, the patient should be taken to the operating room for primary closure. Again, pink serous fluid out of a closed abdomen wound is the early sign for abdominal wound dehiscence and possible evisceration. Burst abdomen. The plasma have high risk for transfusion-associated lung injury. The transfusion lung injury may occur after infusion of the plasma component, and microvascular damage occur in the lung, leading to diffuse infiltrate on imaging and have high rate of mortality. So be wise while using the blood component, when and why, and it's not just a fluid to be infiltrated in the patient. Be used wise. The RBC should be given, the packed RBC should be given at the room air temperature. Don't take it from the fridge and give it to the patient. You will cause hypothermia. And the funny fact that the RBCs or the packed RBCs can cause pyrexia as a reaction. Fresh frozen plasma and the platelets contain citrate anticoagulant that may chelate or chelate the calcium, causing hypocalcemia. So fresh frozen plasma is very common to cause hypocalcemia. Another tip and trick regarding the blood component transfusion. Did you know that the old packed RBCs can cause hyperkalemia? Yes, the packed RBC will rupture contain about 5 to 10 millimole potassium. This is if it's stored for more than 4 to 5 weeks. Uncuffed endotracheal tubes are only used in small children to reduce the risk of tracheal injury, while in adults we use cuffed endotracheal tube. Hypovolemia is the most likely cause of oliguria, and the fluid challenge is the most appropriate action. The blind administration of inotrope to a hypovolemic patient is unwise, with a possible exception of cardiac patient. Take care. So, in hypovolemia, where oliguria, the fluid challenge is the most appropriate action. We have to know and understand what is the principle behind fluid challenge. What challenge we are challenging with fluid. The fluid challenge technique is giving a small amount of fluid in a short time period, and the clinician can assess whether the patient has a preload reserve that can be used to increase the stroke volume with further fluid or not. So, the fluid challenge again involves infusion of a specific amount of intravenous fluid to assess the ventricular preload reserve and subsequent systemic hemodynamic effect. Refeeding syndrome. The refeeding syndrome is a term to describe the metabolic abnormality which may occur in a feeding of a person who has been gone through a period of starvation. The metabolic consequences include hypophosphatemia, hypokalemia, hypomagnesemia, and abnormal fluid balance. Those abnormalities can lead to organ failure. We are humans about flesh and fluids, and our fluids are electrolytes. If you have electrolyte imbalance and trace element imbalance, it's lethal. So hypophosphatemia and hypokalemia and hypomagnesemia are very lethal, can cause organ failure. The problem of refeeding syndrome occurs when the patient hasn't eaten for more than 5 days, and our aim is to refeed him at lower than 50% of the energy and the protein level to prevent as much as possible the refeeding syndrome, because we said it will lead to organ failure, very lethal, hypophosphatemia, hypokalemia, hypomagnesemia, and abnormal fluid balance. The amitriptyline is the treatment of choice in neuropathic pain, while trigeminal neuralgia, carbamazepine is the used drug. So amitriptyline for neuropathic pain, carbamazepine for trigeminal neuralgia. Pain, amitriptyline, while trigeminal neuralgia, carbamazepine, and the diabetic neuropathy, duloxetine. By the way, amitriptyline or gabapentin are the first line for neuropathic pain. Don't confuse them. While in MRCS stating that the diabetic neuropathy is treated with duloxetine. So amitriptyline and pregabalin for neuropathic pain. I know that diabetic neuropathy is considered a neuropathic pain, but in EMRCS stating that duloxetine is the first choice for diabetic neuropathy and the carbamazepine for trigeminal neuralgia. In patients who have hypoalbuminemia, the use of albumin solution will promote the diuresis and manage fluid overload. Platelets are stored at room temperature and must be used soon after collection. This places them in increased risk of culturing gram-positive organism. The iatrogenic infection with gram-negative organism is more likely with packed RBC if they are stored at 4 degrees. Infection with blood product of nature are both rare. But take care, it might occur. Platelets might cause gram-positive organism infection, while the RBCs will cause gram-negative organism infection. It was believed that the enteral nutrition is delayed or the oral feeding is delayed after major surgeries like hemicolectomy or enterotomy. But now, as a part of the enhanced recovery principle, oral intake instead should be resumed soon after surgery, within 24 hours of the surgery. Administration of liquid and even light diet doesn't increase the risk of anastomotic leak. Again, administration of liquid or even light diet doesn't increase the risk of anastomotic leak. We have about 8 liter normal secretion in our body in the 24 hours. So it's not logic to not to drink and start early mobilization. It's a part of the enhanced recovery principle. All local anesthetic have a chemical bond linking an amine or either an amide or ester. Most local anesthetic are of amino-amide type. These have a more favorable side effect profile and are more stable in solution. Procaine and benzocaine have amino ester group. These are metabolized by pseudocholine esterases. Again, benzocaine and procaine have amino ester group and are metabolized by pseudocholine esterases. Remember, lidocaine is an amide. It's local anesthetic and previously was used as antiarrhythmic, unlike right now, because it affects sodium channel axons. It has hepatic metabolism and protein bound and renally excreted, so it's hepatically metabolism and renally excreted. Take care of its toxicity because due to IV or excess administration, increased liver failure or liver dysfunction. Note that acidosis can cause lidocaine to detach from the protein binding. It has drug interaction with beta blocker and ciprofloxacin and phenytoin. Features of toxicity of lidocaine are initial CNS overactivity, cranial CNS overactivity, then depression as lidocaine initially blocks the inhibitory pathway, then blocks both inhibitory and activating pathway. And of course, lidocaine is very famous of cardiac arrhythmia. Take care. If increased doses may be used when combined with adrenaline to limit systemic absorption. Increased doses may be used combined with adrenaline to limit systemic absorption. Adrenaline may be added to the local anesthetic drug to prolong the duration of action. And it permits the usage of higher doses. But take care, it's contraindicated in patients taking MAO and tricyclic antidepressants. The toxicity of bupivacaine is related to the protein binding, and addition of adrenaline to this drug doesn't permit the increase of total dose of bupivacaine. You can increase the dose by using lignocaine and adrenaline, but bupivacaine and adrenaline doesn't increase the dose. 8. The atrachum is degraded by process of ester hydrolysis. This is used non-specific plasma esterases. The criteria for brainstem death testing: deep coma of known etiology, reversible cause excluded, no sedation, and normal electrolyte. The testing for brain death, not the brainstem, the brain death is fixed eye pupils which don't respond to sharp changes into the intensity of incident light, and no corneal reflex, absence of oculovestibular reflexes like no eye movement following the slow injection of at least 50 ml of ice cold water into each ear in turn, the caloric test, no response to supraorbital pressure, and no cough reflex to bronchial stimulation or gag response to pharyngeal stimulation. And as well, there is no observed respiratory effort in response to disconnection of ventilator for long enough, typically 5 minutes, to ensure the elevation of the arterial blood pressure of carbon dioxide to at least 6 kPa, 6.5 kPa in patient with chronic carbon dioxide retention. Adequate oxygenation is ensured by pre-oxygenation and diffusion oxygenation during disconnection. So the brainstem respiratory center is not challenged by the ultimate anoxic drive stimulus. It's simple. The criteria of brainstem death: deep coma of known etiology, reversible cause excluded, no sedation, normal electrolyte. While the testing for brain death: fixed eye pupil, no corneal reflex, absent oculovestibular reflex, no response to supraoperative pressure, no cough reflex, no gag reflex, and no respiratory movement instead of disconnection of ventilator for about 5 minutes. By the way, nobody can declare this except for two appropriately experienced doctors on two separate occasions. Both should be experienced in performing brainstem testing and have at least 5 years postgraduate experience. One of them must be a consultant. Neither can be a member of transplant team if organ donation is contemplated. Take care again. Remember that laryngeal mask is widely used, very easy to insert, device sits in the pharynx and aligned to cover the airway. It has poor control against reflux of gastric content. Paralysis is not usually required to do laryngeal masking. Commonly used in wide range in anesthetic uses, especially in day case surgery. In day case surgery, laryngeal mask is very advised, but take care, it's not suitable for high pressure ventilation. Small amount of PEEP often possible. Remember, the monopolar is a current flow through the diaphragm unit into a handheld device that is controlled by the surgeon, and the electricity can flow from the tip of the device into the patient. The earth electrode is located some distance away. The relatively narrow tip of the diaphragm device produces local heat, and this can be used to vaporize and vulgarate tissue. The current can be adjusted in terms of frequency so that different action can be affected. In cutting mode, sufficient power is applied to the tissue to vaporize the water. The coagulation mode produces coagulum to form instead. Some diaphragm machines can utilize a setting known as blending, that alternative current between cutting and coagulation function. These tend to be used during procedures such as colonoscopic pulpectomy. Bipolar is electric current flow from the electrode to another. However, both electrodes are usually contained within the same device, a pair of forceps. The result is heating localized to the area between the two electrodes of this bipolar device, and surrounding tissue damage is minimum. Take care that the ultrasound-based device like the COSA or harmonica scalpel, they generate high-frequency oscillation that seal and coagulate tissue. They have different energy setting that allows them to dissect and simultaneously seal vessel if required. The COSA device leaves vessel intact that may be divided. The Ligasure device delivers tailored energy level to allow simultaneous hemostasis and dissection. The device senses the impedance of the tissue and tailor energy level accordingly. The key in MRCS is not to memorize the question and the answer only, but to understand every bit of word in each question and understand the idea. Some questions will come the same as you read the question, but others will be from the idea in the question. Here in this question, he is not judging the hand sewing technique versus the stapling, but instead he is asking about the percent of leakage in different organs. The rectal and esophageal surgery have some of the highest rate of anastomotic leak. The right colon anastomosis safer than the left, and the rectal and esophageal surgeries and the colon have higher rate of leakage than the small intestine, because the small bowel anastomosis are most technically forgiving and the leaks are minimal. Factors that might increase the risk of anastomotic leak include previous irradiation, sepsis, malnutrition, poor blood supply, and poor technique. For now, remember that defunction ileostomy may reduce the pressure over the anastomosis over the colon. By the way, in the bowel we use vicryl or absorber suture for anastomosis, while in vascular anastomosis we always use non-absorbable monofilament suture like polypropylene, and the needle is round in both, either vascular or colonic. If you want to visualize the viscera, apply a Bogota bag as long as you are preparing for a secondary look. to visualize the viscera and reassess before entering the OR via the Bogota bag. Bogota bag. It's a clear plastic bag that is cut and sutured to the wound edges, and it's only a temporary measure of closure of the abdomen. It's adopted when the wound can't be closed or when necessitated to have a re-look in the abdomen viscera until definitive management. The wound management is a clear dressing with removable front. It's like a bag, like the stoma bag, but big enough to cover the whole wound, particularly suitable when some granulation tissue is present over the viscera and where high output viscera fistula may be present in a dehiscent wound. So it's for visualization, but when you are expecting some fistula formation and dehiscence with high output fistula. Please don't mix the Bogota bag and the wound manager. Both are different. Most of the endoscopic procedures use glutaraldehyde with an effective antimicrobial agent. It's widely recognized as being a cause of hypersensitivity, so take care. You have to clear out all the glutaraldehyde before using in viscera. Okay? Cell saver or cell salvage device. Those collect the patient's own blood lost during the surgery and then infuse it. There are two main types. Those which wash up the blood cell prior to re-infusion and those which don't wash the blood prior to the re-infusion. The type of the cell saver that wash the blood cell prior to infusion that are more expensive and to purchase and more complicated to operate. However, they reduce the risk of re-infusion contaminated blood back into the patient. The main advantage of the cell saver devices or the cell salvage devices is that they avoid the use of infusion blood from donor to the patient, and this may reduce the risk of blood-borne infection. It may be acceptable to Jehovah's Witness because the patient will take his own blood. We have to respect the belief of the people. And it's contraindicated in malignant disease for risk of facilitating disease dissemination. Take care. The blood salvage device is contraindicated in malignant disease. So the blood salvage device are contraindicated in malignancy and infection. So when you are using blood salvage device, make sure you are using it in clean operation. A patient who has risk factor for a wound infection, which is not itself an indication for scanning, however, he might have abdominal distension, and this together with the history of distension would generally attract the recommendation of imaging. The ultrasound will show the abdominal wall collection and more importantly any phrenic or pelvic collection. Unlike the adult practice, CT scanning is rarely performed in children. If this was adult, we would consider even CT scanning. When you are choosing your suturing material, please think when and who will remove those sutures. A very famous question was a 3-year-old baby who is having orchidopexy in his scrotum. The sutures will be used. What will be used? In the skin, I agree with you, we prefer more to be fine with protein to reduce the infection. But in the scrotum in a 3-year-old baby, who will remove the suture? So we use a fine suture, a very fine because it's a very private, intimate place and very delicate, like the scrotum. We will use, for example, 5-0 Vicryl, and we will choose it rapid. The rapid Vicryl will be absorbed rapidly, unlike the normal Vicryl. The normal Vicryl takes from 1 month to 3 months, but the Vicryl rapid will be absorbed within 15 days maximum. Here, silk is polyfilamentous. This makes it prone to infection and it's non-absorbable, so the infection will be doubled. Some use it because it's cheap and abundant and it's not very easy but it causes very poor cosmesis. We don't like it in plastic surgery at all. So remember that silk is bad and it's braided. It's non-absorbable, lifelong, more prone for infection. This is silk. The polyproline, the propylpropylene or the proline is a permanent synthetic monofilament. It has poor handling because it has memory. When you are trying to knot your knot, if you are not fast enough or good with handling the suture, you will find the whole suture fade away and require severe knotting. It's widely used in vascular anastomosis or even skin with its all variable sizes. So remember, in the face you can use up to 6O proline to make more cosmesis. Of course, in the nerve you can use microsurgery. In the nerve and vascular surgery, use a very fine anastomotic suture up to 9 or 10O proline. To obtain a safe visceral anastomosis, this requires a mucosal to mucosal apposition and adequate vascularity with minimal tension. Remember, stable anastomosis are associated with stable line bleeding, and this may typically occur in the early post-operative phase. They should be managed conservatively, and you must know that this might happen, as most will acetylene. Stabling anastomosis are quicker to perform. Ironically, although they may appear easy, they can carry considerable more potential pitfalls than the hand sewn equivalent, and should be used with caution and by inexperienced hand, especially true if the bowel is very thick-walled. In the inexperienced hand, it might cause catastrophic leakage. Remember the level of evidence. The highest level of evidence is the evidence obtained from systematic review of all relevant randomized control studies. This is level of evidence 1. Level of evidence 2. Evidence derived from at least one probably designed randomized control trial. Level of evidence 3. It's derived from a well-designed pseudo-randomized control trial, alternative allocation or historical controls, like retrospective, not prospective. The prospective more likely to be a level 2. The retrospective is more likely to be level 3. Level 4 evidence. It's evidence derived from a case series or a case report. You have done a case and told us about your result in this case. This is a case report. Level 5. When Dr. Bishoy tell you about his opinion about anything in life without any studies. This is just level 5 evidence, the lowest evidence at all. To decrease and reduce the risk of post-operative wound infection, you can use electrical clipper to remove the body hair on the site of the operation, the day of the operation in the OR, and using povidone iodine or brigmine and chlorhexidine for preparation of the skin is the same. In UK, they prefer more the chlorhexidine. Antibiotic prophylaxis for the prosthesis placement is recommended, but take care that routine use of mechanical bowel preparation is not recommended at all. Take care. Excessive intra-abdominal pressure may cause decreased venous return and hypotension. So during laparoscopy, when using intra-abdominal pneumoperitoneum, it might happen to occur hypotension. So take care. Of course, during laparoscopy, during the varus needle insertion, if you noticed hypotension, you have to look for vascular compromising catastrophe. And if God willing, you are well and good and there is no any vascular bleeding, so take care that the hypotension you have noticed during your laparoscopy might be due to the pneumoperitoneum high pressure. Otherwise, if a vascular catastrophe occurred, a laparotomy is a must. Remember the actions of antibiotic. Most of the antibiotic work by either inhibiting cell wall formation or inhibiting protein synthesis or inhibiting DNA synthesis or the RNA synthesis. The antibiotics that inhibit the cell wall formation are famous of penicillin and cephalosporin. The antibiotics that inhibit the protein synthesis are the aminoglycoside, and they are known for their ototoxicity and nephrotoxicity, and chloramphenicol, macrolide like the erythromycin, and tetracycline and fusidic acid. The antibiotics that used for inhibition of the DNA synthesis like the quinolones like ciprofloxacin and metronidazole and sulfonamide and trimethoprim. Antibiotics that are inhibiting RNA synthesis like rifampicin. The management of a lymph node. First, you have to give a trial of 2 weeks of antibiotics, and if you found the lymph node doesn't change in size and might be resistant or increasing in size, so you have to be suspicious of lymphoma, and you will do a CBC with differential, but you will definitely do an excisional biopsy because you are suspecting lymphoma. Pray for this patient to be anything other than lymphoma. So lymphoma is suspected and diagnosed by excisional biopsy. The fine needle and core biopsy will not allow accurate diagnosis and therefore are not appropriate for the lymphoma suspicious. If you are suspecting lymphoma, the fine needle and core biopsy are not enough for diagnosis. So please do this patient a favor and do him an excision biopsy.